From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome, everyone, to a new episode of JNC Cardio Connect, where we bring the latest in nuclear cardiology straight to your ears. I am Marcelo Di Carli. I'm the editor-in-chief of the Journal of Nuclear Cardiology. And today we're diving into a topic that I think doesn't get enough airtime. That is what we can learn from exercise stress testing, even when the perfusion images are normal. Now, when it comes to stress testing with radionuclide imaging, we have known for a very long time that exercise is always preferred over pharmacological stress. And that's for a good reason. Not only can we reproduce the patient's symptoms, but also we can get information about functional capacity. We can get other hemodynamic and chronotropic markers that will give us some sense of prognosis. Now, these parameters can be particularly useful in those puzzling cases where the patient comes in with symptoms, but the perfusion images are normal and have no ischemic ST segment changes. What do we do with them? Do we really think that all of them are really low risk? Well, that's exactly the question tackled in the paper that we'll be discussing today. It explores the prevalence and impact of additive abnormal stress exercise markers in patients with normal radionuclide perfusion imaging and why these markers might be telling us more than we think. So stay tuned as we unpack this important study with the authors. With me today to discuss the paper is the senior author of this investigation, Dr. Jamison Burke, who is professor of medicine at University of Virginia, where he also serves as the director of nuclear cardiology and echocardiography. Also with us is Stephen Sharping, who completed his internal medicine training at the University of Virginia, and now he is in his cardiology fellowship training program at the University of North Carolina at Chapel Hill. And Diana Lopez, who's assistant professor of medicine at the Brigham and Women's Hospital. She is an expert imager, and Diana wrote an editorial for this paper, so we invited her to be part of this conversation. So welcome the three of you to this podcast. We look forward to our discussion. So Jamie, give us the background that led to the question posed in this manuscript.
Thank you, Marcelo. We appreciate the opportunity to be here and appreciate the opportunity to showcase our work in the JNC. We knew that this was the perfect place for us to showcase this work. I've been interested in a long time on the diagnostic and prognostic value of exercise. I'm also very interested in patients who have normal myocardial perfusion. We know that over time, there's a decreasing prevalence of abnormal studies. We know there's a high rate of negative cardiac catheterization, but yet this is still a population with symptoms and with a substantial number with adverse prognosis. So we sought to look at exercise markers, which we have seen in the past have been prognostically valuable. And we wanted to see what the additive value of multiple of these abnormal markers were, both in terms of the prevalence, so we could get an idea of how much of this there is out there, whether they could have diagnostic significance, which we didn't so much touch in this paper, but then really looking at the prognostic value. And so we wanted to look at heart events, death, non-fatal MI, and see whether this was an area that needed more assessment as a way to look at the added value of functional imaging in this population.
Thank you, Jamie. Stephen, why don't you take us into the methodology that you use for this study and describe the main findings of this investigation for us.
Wonderful. Thank you, Dr. DeCarli and Dr. Lopez, again, for including me in this discussion and for the opportunity to share this work that I'm very proud of with my mentor, Dr. Bork. It's a privilege to share it with the nuclear cardiology community, and it's perfect timing because I'm actually on my stress lab rotation this month. As Jamie mentioned, this is a retrospective observational study of patients who underwent exercise SPECT MPI between 2015 and 2017 at the University of Virginia. And we were examining both the prevalence of these abnormal stress exercise markers and their association with adverse events, which we define by either all-cause mortality or non-fatal MI. The 5 markers we studied during exercise testing included a decreased exercise workload, which we expressed in METs, an abnormal blood pressure response, which included either a hypotensive or hypertensive response to exercise, chronotropic incompetence, impaired heart rate recovery, and finally, a blunted hemodynamic gain index, which integrates both peak systolic blood pressure and peak heart rate compared to rest blood pressure and heart rate. And of note, hemodynamic gain index is not yet widely applied clinically, but it was first introduced in 2019 by the Cleveland Clinic and now has been well validated in many different patient populations. So we thought it was worthwhile to include. Our patient population included anyone who underwent SPECT MPI between 2015 and 2017 with adequate follow-up, who upon secondary review by our nuclear cardiologists were found to have both normal myocardial perfusion imaging and no ischemic EKG depression, i.e. patients who we consider to have had a normal study. Our study population was 892 patients. In the group, the average age was 61, 55% were male, and the average BMI was in the obese range. 2/3 of patients had hypertension, as well as hyperlipidemia. 1/5 had diabetes. Another fifth had known obstructive coronary artery disease, and about half of patients were taking an aspirin and/or statin at the time of the test. Their average Duke treadmill score was 7.2. Over 80% of the patients that we were looking at had been referred for symptoms that were either cardiac or possibly cardiac, 63% of which were chest pain and 41% were dyspnea on exertion. And again, just to reiterate Dr. Bork's point, we thought this group was so important to analyze because many patients come to the clinic with cardiac or possible cardiac symptoms, have a milieu of cardiovascular risk factors, but the rates of ischemia on the exercise SPECT MPI decreased significantly. So we want to know how we can improve our risk stratification in this very representative patient group above perfusion imaging alone or when that perfusion imaging is normal. So to our findings. First, we were very impressed by the high prevalence of these abnormal stress exercise markers on the treadmill. 34.5% of our patients had one abnormal marker, 21% had two, and 9.6% had 3 or more markers of the 5 we studied. This means that only about 1/3 had no abnormalities on the treadmill. The most common marker was our combination variable of abnormal blood pressure response at about 28%, followed by chronotropic incompetence and impaired heart rate recovery at 24% each, hemodynamic gain index at 17, and finally a decreased workload at 9.2%. Our median follow-up was just over 5 years, over which point there were 41 deaths and 37 non-fatal MIs for an annual event rate of 1.78%. When we stratified this event rate by the number of abnormal markers by 0, 1, 2, or 3+, we see the event rate rise in a stepwise fashion from just 1% in those with 0 to 1.6% in those with 1, 2.5% in those with 2, and finally, annual event rate of 3.3% in those with 3 or more abnormal markers. When we applied our Cox proportional hazards analysis, which incorporated both traditional cardiovascular risk factors as well as a Duke treadmill score, we found that the sheer number of abnormal markers was the best predictor of events in our univariable model. And in our multivariable model, each additional marker present corresponded to a 36% relative increase in event rate. Among the individual markers, chronotropic incompetence and hemodynamic gain index were the most predictive of the 5 markers studied. Of note, there were no statistically significant interactions between beta blocker use and the number of abnormal markers present on testing. So in conclusion, in this patient group with normal myocardial perfusion, we found a very high prevalence of abnormal exercise markers, which conferred a stepwise increase in risk for adverse events, which highlights just one advantage of exercise and functional testing for enhancing our risk stratification in patients with normal myocardial perfusion and low risk due treadmill score.
Great summary, Stephen. Thank you very much. We've known for a long time that the inability to get a patient on the treadmill is already a prognostic marker. And now you're providing us with evidence that there's value in adding prognostic markers known to have importance when we do exercise stress testing. Jamie, going back to you now, I'm just thinking my patient had a normal perfusion and had abnormal blood pressure response, chronotropic response, abnormal heart rate recovery. Now, what do I do with this information in terms of investigation? What would be my next step? And what do you think are the implications for this?
Thanks, Marcelo. We were very excited by these results. We were excited by the large prevalence of abnormalities, the fact that there was prognostic significance. I was particularly pleased to see that there was a stepwise increase in risk with each additive marker, which gave us added confidence that this was a real finding. So I think there's both clinical and research implications. On the clinical side, I think that this provides a rationale for using functional testing. It's another check in the box of why functional imaging can be worthwhile. And I think that it can serve as a way to identify which patients do need further study. I think that there is more research needed to understand exactly how to apply these results. On the one hand, a really important follow-up study is going to be understanding how these abnormal markers correlate with symptoms and whether treating things like an abnormal blood pressure response will improve symptoms. On a prognostic side, I think that patients with more of these markers highlight a population where we would be increasingly aware of the need to really aggressively modify risk factors. So patients with multiple markers, I would be really aggressively doubling down on blood pressure control. I would be considering calcium scoring. I would be doing additional things to risk stratify these patient populations to help identify the need for risk factor modification and aggressive medical therapy, rather than looking for patients in whom we would be finding a stenosis. I think that's going to be very important. And then I think we need to look further into some of these markers, such as hemodynamic gain index, to see whether these could be applied more broadly in our stress testing. And I think that this really serves as a call for all of us as interpreting clinicians to be including these markers in our stress test reports in terms of heart rate recovery, in terms of blood pressure response to exercise, things that not all labs are calculating and reporting regularly. I think that this sort of signifies that that is probably worthwhile for them to start doing.
Great. But I have a follow-up question to that. And that is, do we need to worry that patients having these abnormal hemodynamic or heart rate responses may harbor obstructive coronary disease, may not be evident on the myocardial perfusion images?
That's an excellent point. And we know that our perfusion imaging is not perfect. And so, particularly patients who have multiple of these factors, it may be worthwhile to consider additional confirmatory testing, perhaps going on to a PET study where you could do absolute myocardial flow reserve, more accurate perfusion imaging would be worthwhile. This may also be a population where consideration of, I'd mentioned calcium scoring, but maybe even a full coronary angiogram would be worthwhile. So I think it can serve as a call for additional diagnostic and confirmatory testing.
Fantastic. Thank you, Jamie. Diana, you had a chance to dive into this paper, to think through it, and as a clinician and as an imager, give us your thoughts on what you think this means and what you think are implications for this work.
Great. Thank you, Marcelo, and thank you to JNC for the invitation to join this important discussion around the impactful work by Stephen, Jamie, and the other co-authors. I think if we take a step back, it is worth remembering what cardiac testing is actually telling us. And we know that exercise MPI is definitely a powerful tool and has a high sensitivity for detecting angiographically significant CAD. But I think what this study reminds us is that ruling out overt obstructive CAD, while it's important, it's often just the beginning, not the end of the evaluation for our patients. And what really stood out to me is what, Jamie and Stephen have so well highlighted is just the really high prevalence of abnormal exercise hemodynamics, 65%, despite what many would call a quote normal or quote negative study. And these abnormalities carry real prognostic additive weight, as the authors demonstrated. And these findings are incredibly relevant to the patients we see. As Jamie already mentioned, we've seen over the past 2 decades the prevalence of ischemia and MPI has declined, even as the rates of hypertension, diabetes, CKD, and obesity have risen. And even in the absence of obstructive CAD, these patients unfortunately remain at increased risk for adverse events. And it's no surprise then that the 2021 chest pain guidelines say that you probably have at most a 1-year warranty period after a negative stress test, and this includes an exercise SPECT. That's why I think it's so important that we really leverage all the data we already have to refine risk stratification in our patients. And while we do have other tools like the Duke treadmill score, it largely flags what we already know, right? People with short exercise duration, ischemia, and classic chest pain symptoms. Yes, those are higher risk patients, but what about the rest of the patients, or like those in this cohort who had, low risk Duke scores? They're clearly still have notable residual risk with an annualized event nearly approximating 2%. So what now? I think just as Jamie has so well highlighted, this is a call to action. How do we better highlight exercise abnormalities in a way that's digestible for the referring physician? And many markers that we measure in the lab reflect overlapping physiology. So I do think we need to identify what are the high yield ones and communicate them in an effective way that's going to really lead to actionable, meaningful next steps. And besides risk stratification, could this potentially answer questions about why the patients are having symptoms, right? Could they have coronary microvascular disease, chronotropic incompetence, or dysautonomia? And lastly, should we try to develop in the future and implement an exercise risk score in our patients? We just need to remember that there are well-established limitations of applying uniform cutoffs across sexes, as women often exhibit different physiological responses to exercise. So we may need to think a little bit about the thresholds as we further refine what these risk scores could be. So definitely exciting. I think it's just an important study because I think we need to really highlight how the data we're already collecting is highly impactful. Great work.
Thank you, Diana, and thank you, Stephen and Jamie, for being part of the podcast. We are very keen in building the evidence to support best practice in our field. And I have to say, thank you for sending this paper. Not only is it great science, but also it is a reminder of why should we be doing exercise stress testing in our patients. It has enormous implications for the future. How do we leverage this information in the context of exercise PET that we will be able to do with flurpiridaz? So I think it is very informative about the way we should go into the future. Thank you again for considering the journal for your work. And I really thank you for your time today.